So the first chief complaint you pick up for the day says radiation injury, and you're thinking, what? What is that, and what am I supposed to do with it?
Interestingly, the next patient you pick up in the same ED is eye pain after welding. And you wonder, am I dealing with something serious like a globe injury?
In this episode of Critical Decisions in Emergency Medicine, we will talk about acute radiation sickness, specifically identification and management.
We will also talk about ocular foreign bodies, including their evaluation and treatment, including when you need urgent ophthalmologic evaluation.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices all over the world.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the November 2025 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
There are also a lot of other features such as the Critical ECG, Critical Procedure, and as our listeners know, one of my favorite, the LLSA Literature Review.
So for our first lesson this month, it's Fallout Acute Radiation Sickness. Thank you to Dr. Rohan Vasisht and Shan Follett for writing this article.
You know, Danya, despite how much radiation we order on patients, we don't really think of radiation as a cause of illness, unless maybe you're near a radiation source.
You're absolutely right. We tend to think of radiation just as something that we can use as a diagnostic purpose, and we sometimes forget that ionizing radiation has a range of physiologic effects on the human body, and that acute radiation sickness may present with a variety of signs and symptoms, leading to and including death at times. Thankfully, though, these cases are quite rare. However, sometimes they can lead to mass casualty events, which is why it's really important that we know how to identify them and manage them.
Okay, so I guess let's start with when should we actually consider acute radiation sickness in a patient presenting to the ED?
Well, it's usually when patients come in with a history that suggests exposure to ionizing radiation, whether it's a partial body or a whole body exposure, and then who also have compatible signs and symptoms. It's really important that we know what's the source of the ionizing radiation, how far the patient was from the source, the duration of exposure, and if they had any level of shielding at the time.
That makes sense. So who is actually at risk then for these radiation exposures?
The article really goes into detail about that, but we need to think about it just like you said with individuals near nuclear reactors or industrial or research facilities, healthcare workers who use radiation for their procedures like interventional cardiology or radiology, those working with sealed radiation sources in medicine and the industry, or those who work with unsealed low activity radioactive materials such as nuclear medicine. Another group of people we got to think about are the personnel who are involved in transporting that radioactive material and individuals who are handling or coming into contact with radioactive waste. And it's important to remember that exposure may be external or internal.
Let's take a step back. What did you mean by external and internal? And why is it important to understand that?
So external radiation exposure is the most common route of exposure where you're irradiated by a source outside of the body. And it's really important to know that because those individuals who are strictly irradiated that way are not contaminated and pose no risk to those around them. So those are the ones who are exposed to radiography equipment, therapeutic treatments, nuclear reactors, and so on. And interestingly, medical exposures were responsible for 60% of radiation accidents and overexposures. And it's important to remember that those with external radiation exposure may have other concomitant injuries as well, such as thermal burns and trauma from penetrating or blunt injuries. Another thing to remember that with those individuals, they may actually have a retained penetrating piece of radioactive material that could lead to continued radiation exposure. Now, internal radiation exposure is quite rare, but that's what you see in the cases of ingestion, inhalation, injection, or absorption, whether it's accidental or intentional. And it's important to recognize that because these individuals are contaminated at the arrival to the emergency department and pose a threat to the healthcare team.
Okay, that makes sense. Another basic question, how do we quantify the amount of radiation to understand that it's a serious exposure?
So we usually use The gray unit, which is the standard international unit used to describe the amount of absorbed radiation. And it's equivalent to 100 rads, which is what we usually use in the US to measure. There's this term called LD5060, which is used to denote the level of lethal radiation dose that's required to kill 50% of an irradiated population at 60 days. And the numbers that we think about with that LD50/60 is that for people to survive that, if they have basic supportive care and antibiotics, then you need to handle up to 4.5 to 7 gray. If you have access to advanced therapies, then 7 to 9 gray would be as much as can be dealt with. But doses higher than 10 gray approach 100% mortality, no matter how much access you have to aggressive treatment.
Got it. Now let's move on to how patients would present. What are the phases of acute radiation sickness?
So there are 4 phases: prodromal, latent, manifest illness, and recovery phases. The exact characteristics of the prodromal and latent phases will vary depending on the dose of the radiation and the specific syndrome that will eventually develop. The prodrome is things like nausea, vomiting, diarrhea, and that can be minutes or days after the radiation exposure and can last for several days. And that's usually absent with low exposures that are less than 1 gray. The latent phase is relatively asymptomatic and it can be anywhere from days to weeks. But of course, when we're talking about a really high dose of radiation, then that can only be a few hours. The manifest illness phase is basically the actual symptoms of the radiation sickness. And the 3 classic syndromes we think about are hematopoietic, GI, and CNS or cardiovascular syndromes. And these have notable overlap. It's also important to remember that cutaneous manifestations may happen with or without these syndromes. Interestingly, turning into Superman is not one of these syndromes, so you should not be looking for that. That said, it really depends on how much radiation you got exposed to see which of these syndromes develop. With the hematopoietic syndrome, you're going to be thinking that these patients are going to have pancytopenia. Lymphopenia is the one that occurs before the other cell lines and is the one that helps you understand their survival and their outcome. Neutropenia occurs at around the 2-week mark. With GI symptoms, that's usually when you're talking about higher doses. And if they reach somewhere from 6 to 10 gray, which is a lot, those are the ones that can have significant abdominal pain, GI bleeding, and so on. And for these patients, you really need to focus on hydration, electrolyte repletion, and they may require TPN. If those patients end up with a fever, you need to think of bacterial gut translocation and treat them appropriately with antibiotics. If somebody has a significant exposure, so more than 10 gray to their whole body, then that's when they have cardiovascular CNS syndromes. The neuroabnormalities can include things like seizures, decreased level of consciousness, decreased reflexes, and their brain imaging would show generalized intracranial edema. Unfortunately, these patients are unlikely to survive, and they would typically die within 3 days of the symptom onset. The common manifestation that we talked about as well is the cutaneous symptoms, which may occur with or without the other manifestations, and it can be caused by relatively lower radiation doses, as low as 2 gray. And although it's not fatal, it can lead to permanent disfigurement. It's important to remember that knowing when the erythema of the skin develops, then it allows us to know how much radiation exposure the patient had, because the earlier it is, the higher dose of ionizing radiation thought to be absorbed by the skin. And that can be difficult to tell with darker skin. And with high dose exposures, it's definitely a lot more than erythema. You're talking about pruritus, paresthesia, and pain. As for the recovery phase, it will vary by the specific exposure and syndrome. Complete recovery takes weeks to months for exposures from 2 to 6 gray and months to years for exposure of 6 to 8 gray. And these patients are going to need follow-up care, which includes monitoring for developing malignancies.
That makes a lot of sense. And really good tip about monitoring the timing of the development of cutaneous symptoms. So what about decontamination? How do we do that?
So this was really interesting to me, as it's very different than what I think of when we talk about decon with tox cases. Patients here need to be evaluated for any necessary life or limb-saving interventions before undergoing decontamination, rather than the other way around. And that's because contamination from radioactive material is not typically immediately life-threatening. That's number one. And number two, like we said before, a lot of it is external sources rather than internal. Now, if there are just a few individuals, we can triage them the conventional way, especially if they have any other co-injuries and so on. But for mass casualty incidents, then we need to use traditional mass casualty triage systems such as the START, the simple triage and rapid treatment, or the SALT, sort, assess, life-saving interventions and treatment transport. And there are some radiation-specific triaging and scoring systems that can be performed that we're going to talk about later. If this is a mass casualty incident, we need to have zones and separate the patients in order to protect medical personnel and non-exposed patients. You have the dirty zone that's covered in plastic and the staff are dressed a certain way, and then a clean zone. The staff in the contaminated zones need to wear water-resistant clothing. Surgical masks are fine, but N95 are preferable. And those are ones who would want to wear like two sets of gloves. The first that's taped down to the clothing, and then the second on top of that. That's frequently changed between patients and contaminated items. And if available, the staff should be wearing personal radiation meters under their protective clothing. As for the actual decontamination itself, then the patient should have their clothing removed and disposed of with hazardous waste. And then a full body survey needs to be performed to look for shrapnel or radioactive material. So any radioactive remnants need to be carefully removed with forceps and placed in a lead container. And if possible, if we have a Geiger counter to assess the background levels of radiation and so on, then that would be great. An interesting tip the article has is that the level of lung contamination specifically can be determined by swabbing the patient's nares. Now, if the patient has wounds, then the wounds should be washed. If we don't know what the contaminant is, then we can just use over-the-counter soap and warm water, a mild detergent soap, or 3% hydrogen peroxide. However, if we know exactly what the contaminant was, then there are specific decontamination solutions depending on what that contaminant is. Another important tip here is that areas of intact skin should not be heavily scrubbed because skin breakdown can then lead to internal contamination. And then while we're decontaminating after the end of each cycle, we need to try to compare, if we're able to, the patient's current radiation level to the pre-established baseline and the levels of background radiation to know when to stop.
Got it. That makes a lot of sense. Hopefully, all of our emergency departments have some sort of a protocol that outlines this because these are rare events and a lot of details to keep track of. So, how about triaging patients with acute radiation sickness? How do we do that?
So one important element is knowing the timeline so that we know when is it going to show up, like we talked about with the prodrome, latent phase, and so on. Now, the RITM recommended triage systems take into consideration the patient's clinical symptoms, an estimate of the whole body radiation dose based on the lab evaluation, and radiation maps made by computer models that use real-time radiation measurements in the environment. There is another triage and scoring system called Metropol, the European Medical Treatment Protocols for Radiation Accident Victims, that incorporate multiple points of information into calculating that. Now, once you do that, which also includes symptoms, lab values, and so on, then you assign each organ system a degree. Your organ systems are H, C, G, and N. And then the combination of the organ system and the degree is called a grading code. So it can be things like H3, C1, G2, N0. And then that tells you how affected each system is. And then the generated grading code allows the physician to categorize the patients into a response category, which is determined by the highest grade in that grading code. It's 1 to 4. So 1, those are patients that can go out for follow-up care daily and so on. 2 are those with moderate injuries and have to be reassessed every 12 hours. 3, they need to be reassessed every 6 hours. And then 4, those are the ones with severely damaging injuries where they need a complete reassessment every 6 hours for the first 3 days. So again, like you mentioned earlier, Wendy, it's really important that we have these protocols clear because this is a very specific way of handling injuries that we're not necessarily used to on our day-to-day basis.
That makes sense. So we talked a little bit about recognizing the symptoms, triaging decontamination, etc. Let's talk about treatment. what do we actually do for these patients once they arrive?
So we start with the life-saving interventions, thorough decon as appropriate, and then the complex multidisciplinary evaluation according to our specific hospital's disaster plan. Like we've mentioned numerous times today, documenting the timeline of the exposure and the onset of symptoms is important because that allows us to figure out how much exposure there is, specifically the timing of the onset of the nausea, the vomiting, and the skin erythema. And then, of course, there have specific calculations like they have the vomiting within 2 hours, then it's likely that the dose was higher than 2 gray, and so on and so forth. So that allows us to figure this out. There's also an interesting figure in the article about the nomogram for lymphocyte depletion following acute radiation exposure that tries to calculate how much do you think they were exposed to in comparison to their lymphocyte count, like we said, which is the most important one to know how effective the cell lines are. Now, in patients who have myelosuppression, those are the ones who are recommended to have the GCSF or GMC stimulating factors as soon as possible, basically to stimulate their cell lines. And then down the line, stem cell transplantation may be needed as well. It's really a very detailed algorithm of how to manage each specific injury depending on what we think may have been the source of exposure. And again, how much information we know, because as we all know in the emergency department, sometimes we just operate with very minimal, limited information. What's important as well is that if patients have cutaneous radiation syndrome, that is under the purview of a burn specialist. So we need to think about that if we don't have those facilities and there's no other concerns, and that's somebody we need to involve in the care of the patient. And with the inflammation, we can use ointments and topical steroids as well to help control the inflammation. If there's any concern for internal contamination, then we need to definitely involve radiation specialists and hematology specialists because at that point it's pretty severe exposure and the treatment is primarily supportive. In patients who have a suspected acute radiation sickness, antibiotics should be considered, like we talked about earlier. They may have gut bacteria translocation from GI injuries, as well as the neutropenia that can occur with an infected cell line.
Well, thank you, Danya, for taking us through this lesson, and thank you to our authors for writing it. It is definitely a rare condition, but one that we have to be prepared of, not just if you practice near a nuclear reactor, because we learned that 60% of radiation exposures and accidents actually occur in the medical setting. If you think about radiography equipment and other radioactive agents that may be involved. And so when we do have a patient presenting with potential radiation exposure, we have to think about potential external sources of exposure where these patients would have less risk to the healthcare team as opposed to internal radiation exposure if they had some sort of an ingestion, inhalation, absorption process that could pose a further exposure risk to the healthcare team. And so that does lead to that differentiation that we talked about, where we do want to address life-threatening injuries first before we think about decontamination, which the article definitely takes us through a very detailed protocol that I hope all of us can review with our emergency departments to ensure we're doing it properly. But specific to acute radiation sickness, we learned that there are 4 phases: prodromal, latent, manifest, illness, and recovery phase. And really the timeline, the shorter it is, then that suggests a higher dose of radiation exposure. And so not only do we need to pay attention to the time of onset for initial GI type symptoms, which is very common, or severity of multi-organ involvement, specifically cardiovascular or CNS symptoms, suggest really high radiation exposure. And then the timing of development of cutaneous symptoms, that all can give us hints as to how severe was the exposure and what to anticipate in managing these patients. We also talked a little bit about how some of the laboratory studies that can also help us gauge the severity and also anticipate the trajectory of these patients, specifically using our CBC or lymphocyte count. And the article provides also resources on a nomogram. that can predict the lymphocyte depletion after acute radiation exposure. A lot of the management we're providing is, of course, supportive in terms of volume resuscitation from nausea, vomiting, GI losses, as well as hemodynamic support if need be. And then don't forget about, again, cutaneous symptoms that, while have some overlap with other thermal injuries, is also unique in its own, but can benefit from consultation with burn specialists.
Well, thank you so much, Wendy, for summarizing this article that was so full of pearls. We barely covered the tip of the iceberg there. Definitely worth reviewing this very rare but very scary topic. Our ECG this month is on recurrent palpitations in a middle-aged man who has WPW. I know we talk a lot about WPW. We actually talked about this last month as well. And the reason it is always worthy of a conversation is because it's worth remembering that there are 3 classic dysrhythmias in WPW patients that can be managed differently. They're not all equal, especially when we're comparing them to the management of these dysrhythmias in a non-WPW patient. The article goes into detail on the characteristics of WPW-related antidromic AVRT and highlights that patients can be treated with synchronized cardioversion or procainamide. So definitely worth looking into.
And moving on to our clinical pediatrics this month, this is a case of a 7-year-old girl with developmental delay who is presenting with altered mental status. You find that the patient on your exam has some abnormal posturing, including some episodes of rigidity and decreased tone that the family reports to be abnormal, and that they have had recent URI-type symptoms with fever, cough, and congestion. And their vital signs is also notable for hypotension, tachycardia, a low-grade fever. And you also find that they have some dark circles around her eyes and some hyperpigmentation of her oral mucous membranes, which the family also reports to be new. In terms of your lab workup, you find that she's actually hypoglycemic with a glucose less than 40 and also has an anion gap acidosis. And while in the ED, the patient has some more episodes of hypoglycemia that prompts you to admit the patient for further management.
Adrenal insufficiency is categorized into 3 types. The primary adrenal insufficiency from dysfunction at the level of the adrenal cortex, secondary at the level of the pituitary, and tertiary at the level of the hypothalamus. Patients with primary adrenal insufficiency often have glucocorticoid and mineralocorticoid deficiencies. However, with the central aspect of it, which is your pituitary and hypothalamus, they have spared mineralocorticoid function, but their deficiency is in glucocorticoid. It's important to remember the disruption of these physiologic processes. Primary adrenal insufficiency causes hyponatremia, hyperkalemia, hypoglycemia, and anion gap metabolic acidosis from that ketone production, as well as hypotension from decreased vascular tone. These patients can also have the enhanced pigmentation that's present in more than 90%. Patients can come in with symptoms of these metabolic abnormalities with confusion, fatigue, lethargy, poor weight gain, nausea, vomiting, vague abdominal pain. But sometimes in the early stages, the presentation can be a lot more subtle. I know that we talk a lot in our textbooks from a recollection of pediatrics and internal medicine is that we do ACTH stimulation tests, but that's not really practical in the emergency department, especially when someone is unwell and we think they're having an ongoing adrenal crisis. In these patients, it would make sense for us to order the plasma cortisol and ACTH levels, which can be used to assess the hypothalamus pituitary adrenal axis function. Now, hydrocortisone is the first choice replacement treatment because of its short half-life, rapid peak in plasma concentration, lower potency, and association with fewer adverse effects compared to prednisolone and dexamethasone. So that's definitely a great review of a very rare case. Now, for our LLSA Literature review this month, we have an article about managing patients with acute visual loss that was published by Adlow and Huffman in Annals of Emergency Medicine in 2022.
And the authors of this article really provides us with a diagnostic framework to approaching acute visual loss. And they categorize acute vision loss into four major categories of etiology, whether to think about it as orbital or ocular pathology, ocular neurovascular dysfunction, brain related pathology, or functional neurological disease. And having this framework allows us to really think about the particular history elements that can help further tease this out. Is the patient presenting with persistent or transient vision loss, monocular or binocular vision loss, and if there's any associated pain or redness with that? Obviously, the timing of symptom onset is very important, as well as whether or not the patient has any particular cardiovascular risk factors, any inflammatory symptoms that may increase our suspicion for maybe giant cell arteritis, and other neurologic symptoms that may increase our suspicion for brain pathology. So there's a great table in this section that breaks this down into the four categories of pathology, as well as further breaking it down into monocular versus binocular vision loss, and as well as persistent versus transient etiologies. So I think this is a really, really helpful framework to think about. In terms of our exam of the patient, we certainly want to evaluate not only the ocular position, the patient's extraocular movements, the pupillary exam, including the swaying light test, visual acuity testing, visual field testing. Don't forget about measuring intraocular pressure and doing your full ophthalmologic exam, including a slit lamp exam if needed. If you're worried about certain etiologies, maybe there's some utility in laboratory testing. Glucose levels can help us tease out certainly hyper or hypoglycemic causes. A lactate level may be helpful if you're worried about methanol toxicity. And then, of course, more commonly, we think about inflammatory markers if we're worried about giant cell arteritis. And then in terms of imaging, if you're worried about orbital compression, certainly a CT can be helpful. An MRI can be used to evaluate for stroke type symptoms or neuromyelitis optica. And of course, in the ED, we often think about ocular point of care ultrasound, which can be used to evaluate for vitreous hemorrhages, vitreous detachment, or retinal detachment, and also optic nerve sheath diameter as a surrogate evaluation for papilledema. And then finally, in terms of the specific treatments, most of the time when patients are presenting with acute vision loss, we would need consultation with ophthalmology, but emergent treatment is also needed for certain disease subtypes, such as acute neural ankle closure glaucoma and central retinal artery occlusion. If you are dealing with a case of concern for giant cell arteritis, there should be low threshold for empirically treating with high-dose glucocorticoids, and don't be afraid about its potential effect on decreasing the diagnostic utility of a biopsy, as long as that can be done within 2 weeks.
Well, a great review of a great article, definitely worth looking at the details given the severity and the scariness of this initial complaint. Now, for a critical procedure this month, it's active external rewarming of hypothermic patients, which sounds quite fitting for the season since the temperatures are starting to drop in a lot of parts of the Northern Hemisphere. Now, we all know that rewarming of hypothermic patients can be done passively, actively, externally, internally, which is like our invasive methods. And that really depends on the patient's clinical presentation, their core temperature, and their ability to generate heat. What we're talking about here is the active external type. Now, we need to keep in mind that one of the risks is overshooting of the goal temperature and then hyperthermia. If it is not done correctly, then burn injuries can cause a problem. And then as well, vasodilation that can cause relative hypovolemia, a core temperature after a drop, and rewarming acidosis.
For the actual procedure itself, you do want to have continuous temperature monitoring if that is available to you to be able to watch, of course, how fast you're able to correct the temperature and avoid this overshooting that Danya just mentioned. We do want to do all the other maneuvers for passive external rewarming, like warming the environment, removing the patient's clothes, and dry the patient if they have any wet skin or hair. And in terms of the equipment that you can use, if you do have access to some of those water-filled heating blankets. You can place one under the patient. If you don't have one of those devices, you can just place a warm blanket under the patient. And then over the patient, you can use one of those forced air convection heating systems, or simply a warm blanket as well if you don't have access to one of these active rewarming devices. And then you can also use as adjuncts other minimally invasive rewarming methods such as warm IV fluids or warm humidified air. Now, moving on to our critical cases in orthopedics and trauma this month. This is a case of a 33-year-old man who is presenting with a foot injury after jumping off a pontoon onto a shallow surface. He experienced immediate pain, was not able to bear any weight, and had a significant swelling of his foot that you noticed to be most notable in his midfoot area, with pain on palpation at the basis of the second and third metatarsals. You get some x-rays and you find
Ta ta ta! A Lisfranc injury. I really need to work on my sound effect. Now, a Lisfranc injury is a tarsal metatarsal dislocation that occurs and disrupts the articulation between the medial cuneiform and the base of the second metatarsal. So basically the midfoot, where this patient is having a lot of their swelling. Now, it typically results from high energy mechanism. However, it can also result from a low energy mechanism, such as abruptly planting the foot in a twisted position. A classic test that we can apply is something called the piano key test to assess for the stability of the tarsal metatarsal joint by stabilizing the midfoot and then moving the head of each metatarsal. It's also really important to do a thorough neurovascular exam, specifically the dorsalis pedis artery and deep peroneal nerve. The x-rays that we need to get should include an anterior, posterior, a lateral, and oblique view. And we can see widening of the space between the base of the first and second metatarsals or a step-off of the tarsal metatarsal joint. There's something called a Fleck sign, which is sometimes seen, which is a small bony avulsion from the second metatarsal or the medial cuneiform that can give us a hint that there's a Lisfranc injury. What's important and scary, actually, if you think about it, is that 20% of the injuries can be missed on the initial x-ray. And that's why we sometimes need a weight-bearing x-ray series. I don't think I've ever ordered a weight-bearing x-ray series in the emergency department. The alternative would be a CT scan. I would think it's also quite logistically challenging to weight bear when you broke your foot. An MRI can evaluate the ligamentous structure of the Lisfranc complex. However, as we all know, that's not the most feasible in the ED.
in terms of management, certainly we want to provide pain control and reduction of the tarsal metatarsal joint with immobilization using a short leg splint. You want to elevate the leg and instruct the patient to do so to reduce swelling, which would help our orthopedic consultants in their ability to do their open reduction internal fixation, which is often needed.
And moving on to our critical image this month, it's a case of an 11-year-old boy with abdominal pain after a fall. He basically tripped and hit his epigastric region against a toy cart. And then for 12 hours, he's been having increased pain and vomiting and pain with movements such as walking. On exam, he's tender in the epigastric region and left upper quadrant, and he also has guarding. So a fast exam is done. It is negative. A CT with IV contrast is obtained, and
You find a duodenal injury.
okay, you can't do that without doing a sound effect. How is it that I have to do sound effects and you don't?
Da, da, da.
Yes, better. Thank you.
So we generally think about duodenal injuries in children occurring from blunt epigastric injury, such as from a bicycle handlebar. However, in children under 3 years old, we do have to also think about non-accidental trauma. CT can be insensitive in early presentation, so if you're highly suspicious based on the mechanism and the patient's symptoms, you do want to observe these patients to follow their case. But if you were to get a CT, the one learning point is that you actually do not want any enteral contrast because there can be extraluminal contrast leak in only a small percentage of patients who needs operative intervention. Some other findings you can look for are pneumoperitoneum, but again, that only occurs in about half of the patients. And so this is something that I think we just have to have a high index of suspicion for. In this particular case, the patient was treated with antibiotics for the concern of a duodenal injury and ultimately underwent a laparoscopy. And they did find an area of microperforation, but did not require any resection or repair.
So, despite how scary this case is, it sounds like it ended up quite okay, I guess. So for our second lesson this month, we have eyesore, ocular foreign bodies. Thank you to Dr. Nicholas Baxter, Dustin Williams, and Fred Mehta for writing this article. This was really eye-opening for me to find out that around 1 million ED visits annually are for eye-related complaints. And on some shifts, I feel like half of them show up just for me. We need to know how to manage ocular foreign bodies, including specifically when to get ophtho involved to prevent vision loss, because not everyone is lucky to have that service immediately available to them.
Yes, very good point. And so we generally think about ocular foreign bodies associated with certain activities that may be high risk, such as grinding or welding without goggles, and the patient may present with sudden onset discomfort of their eyes without any relief. And we need to do quite thorough ocular exam to assess, of course, the extent of the injury and then how to manage that.
Let's start with visual acuity, the vital sign of the eye. Any tips on measuring that?
We're all pretty familiar with this, but a few tips and reminders are that if the patient normally wears corrective lenses, then you should perform the visual acuity testing with those glasses, unless the patient only wears contact lenses. Because in that case, you have to think about what the injury you're maybe dealing with, as well as whether you need to do any fluorescein staining. In those situations, you would want to have the patient remove their contact lenses. And in terms of the actual measurement itself, we are looking at, if you're using any of those eye charts like the Snellen eye chart, you're documenting the patient's visual acuity as the last line that the patient can identify at least half of the letters correctly. And you would actually add to that documentation also the number of letters missed. So, for example, if the patient was able to read at the 2040 line, but missed two of the letters, you would write the visual acuity as 2040 minus 2.
Great tip. So what about other components of the general eye exam?
There's a lot we can gain just by the external exam. We want to look at the eye position itself. Is there any sign of a recession of the globe or enophthalmos, or protrusion of the globe or exophthalmos? And you want to look for, of course, any signs of other facial or eye external trauma that might raise your suspicion and concern for globe injury. And the other components of the eye exam, of course, include extraocular movements. You want to look at the eyes themselves at rest, if they're conjugate or disconjugate, if there's any cranial nerve palsies with restricted eye movements, or potential entrapment. To do that, as we know, we often have the patient follow our finger in the letter of a H in the ear. And then another component of the external exam includes the pupillary assessment, and that includes shining the light directly at each pupil as well as with the swinging flashlight test to assess for consensual pupillary response, where one pupil may constrict when the light is actually shined in the opposite eye. Some of the things you may find with patients who have ocular injuries is that they may have pain with the pupillary exam because there could be some sort of uveitis or deep inflammation, or you may even find a relative afferent pupillary defect that can sometimes occur with trauma to the eye involving whether the vitreous, retinal, or even the optic nerve. Now, some of our patients come in with asymmetric sized pupils and a sequoia that is physiologic, but those are generally only a 2 to 3 millimeter difference, and they should have a normal response to light. Anything that is not that case, then you should be worried about some abnormal pathology, of course. Sometimes you may even find an irregularly shaped pupil because of ciliary muscle injury. And don't forget that open globe injuries can also present sometimes with a tear-shaped pupil with the tip of the tear point pointing towards the penetrating point of injury. Don't forget that people can also have lens dislocations, and that patient can present with a quivering and dilated pupil that does not react appropriately to light. And then, of course, assessment should also include the cornea and the anterior chamber for any sort of foreign bodies or hyphema.
Great reminders of examining a very tiny part of the body that's very important. So let's go over the slit lamp exam, the bane of my existence.
With all the eye complaints you see. All right. This is something that is important for all of us to be facile with. And part of it comes from good preparation. So you can get your slit lamp all set up and get familiarized and refreshed on all of its functions and movements before you bring the patient in, which of course adds another layer of reassurance to the patient that you know what you're doing. And so in terms of setup, you want to get the chin and the headrest all cleaned with alcohol wipe. You can adjust the focus and the depth of the slit lamp by just using your hand as an initial source of focus and get familiarized again with the movement of all the parts. Majority of the movement you're dealing with once the patient is in position with their head in the headrest is to use that joystick to move forward or backward to adjust the focus and the depth, to move the joystick laterally to allow the lateral side-to-side scanning and shift the focus of the magnification. And then you can, of course, also rotate the joystick, which then moves your line of vision, either cephalad with clockwise rotation or caudal if using counterclockwise rotation. And ultimately, if you do get yourself into a good position, good focus, and directly at the area of interest, such as if you're going to be moving on to doing some sort of foreign body removal, you can actually use the knob that is near the joystick to keep all of these movements locked so that you can stay in focus and keep your hands free to perform the foreign body removal. In terms of the light on the slit lamp, usually you use it at a 45-degree angle to your left when examining the patient's right eye, and then vice versa in the other direction. And for most examinations, you want the light to be at the maximum size, medium intensity, and the color white, and then flip over to the cobalt blue filter when you're using your fluorescein staining. If your patient is particularly photophobic, you can actually use the green or red filtered light, which is a good tip. And then a few other tips in terms of your anterior segment examination. You can actually, at this point, adjust the beam of your light to more narrow, 1 millimeter wide and 3 millimeter high. That will give you a better assessment of your cell and flare findings in terms of floating reflective particles in the anterior chamber or that hazy, foggy appearance of the increased protein concentration. And then finally, in terms of the fluorescein staining itself, you would do so by applying the fluorescein strip to the inferior eyelid and have the patient blink to remove any excess and use that cobalt blue light that we mentioned. And if you do find a corneal defect, then you can apply more fluorescein directly over that defect and see if there's any sort of leakage of fluid to suggest a full thickness corneal or scleral laceration.
Great tips on using a slit lamp. So, how should pain be managed in patients who are coming in with ocular foreign bodies?
Well, we often use ocular anesthetic drops, whether that is tetracaine or proparacaine. And usually we want to use just one drop in the affected eye because we want to avoid overuse since repeated uses can damage the cornea. Another option, if the patient has a lot of pain that's not controlled just with the anesthetic, is you can use cycloplegic eye drops. And that would then, of course, reduce eye pain because you're limiting pupillary movement. And that's generally your atropine, cyclopentolate, or topiramate. The caveat is that cycloplegic medications are contraindicated with patients with shallow anterior chambers, such as when you're dealing with closed angle glaucoma, or if they, of course, have any allergies to this medication. Another consideration would be topical NSAIDs, especially if you're dealing with foreign bodies or allergic conjunctivitis, UV keratitis, or corneal abrasions. And of course, we have access to our standard pain control regimens that are non ophthalmologic en route that we can give, whether it's oral, IM, or intravenous.
Great tips. So let's talk a little bit more about corneal lacerations and open globe injuries. How should we evaluate and manage these?
We generally think about the potential of these injuries based on, again, the event surrounding the mechanism. So, like we said, high risk would be welding injuries or grinding without eye protection, or maybe even hammering metal, or even sometimes from other machineries like lawnmowers and such. So, if you're dealing with somebody presenting with acute sudden eye pain after an event like that, you should be suspicious. If you are suspecting a globe injury, we want to avoid any pressure to the globe. And so that does mean tonometry and lid aversion are contraindications. Also, even our point of care ultrasound is a relative contraindication. Some signs that may suggest a globe injury also include a shallow anterior chamber that we mentioned, a hyphema, the irregular iris or pupil that we also mentioned, or even a traumatic cataract. In cases of blunt ocular trauma, we also want to carefully examine the limbus, which is the border between the sclera and the cornea, since that is the area that's most likely to be the area of penetration or injury. There should be a low threshold in obtaining a CT. You can get a contrasted CT scan, which can increase your sensitivity somewhat, only about 50 to 77% or so, to evaluate. Of course, get our opto colleagues involved as well. Now, remember, while MRI is generally a great tool for a lot of detailed assessments, in the case of a suspected metal foreign body injury, that would be contraindicated because we don't want that foreign body to move around.
You definitely do not want it to move around. So, how about corneal foreign bodies and rust rings?
If a patient is presenting with a corneal foreign body, we want to remove it within the first 24 hours because they can get embedded in the stroma over time, which then makes it harder to remove. Occasionally, they can also get trapped in the eyelid, so look there also, in addition to, of course, of the cornea. If you can remove it just with a saline-soaked cotton tip applicator, that's great. Sometimes you can also irrigate the foreign body. Just be careful in how you do so because you actually don't want to use a contact lens mechanism to irrigate the foreign body. You just want to use lactated ringers because its pH is closest to the eye's normal pH and have the tubing connected to the bag and directed tangentially to the cornea, not directly against it, since that can also further embed the foreign body itself. Now, we generally talk about and learn about how to remove the foreign body with, of course, our slit lamp magnification and another device, such as with a needle, or you may even have a specialized device, corneal spud, which is a stainless steel tip attached to a handle, and that can be used to carve or lift off this embedded foreign body. And to do so, of course, we want to have the patient appropriately positioned in the slit lamp, which the additive benefit is that if they have their head in the slit lamp, they can't move forward even more and avoids additional potential injury during the foreign body removal process. And we want to try and approach the foreign body from the periphery and not cross the patient's line of vision, which may, of course, freak them out. Now, sometimes the patient may present with the foreign body already gone, and you may only find rust rings. That is a reaction from our tears with the iron component of the foreign body that leads to oxidation. And we do want to think about whether or not we should remove these or ophthalmology would be more appropriate to do so. If the patient can be seen by ophthalmology within the next day, you can let your colleagues do so because usually these rust rings can reaccumulate. But if they're not able to see ophtho in this urgent manner, then we would remove the rust ring in the ED and have the patient return for a repeat examination. And finally, remember that after your removal of the foreign body and the rust ring, You need to treat the corneal abrasion aspect of the injury, which is with the antibiotics. Eye patches are actually contraindicated in organic foreign bodies in patients who wear contact lenses because of the higher risk for bacterial infections.
Well, great summary of how to manage ocular foreign bodies and ocular injuries. It was a great reminder of how to do a thorough exam of the eye, specifically about the visual acuity being the vital sign of the eye, and specifically how to deal with it when a patient can sort of read the line, but not all of it. It's important to remember that a general inspection of the eye is essential to look for signs of trauma, protrusion of the globe, or injury of the bony orbit, but not the globe itself, as well as a thorough pupil exam and how to manage anisocoria, which can be physiologic, but may also signify an injury, especially if you see an irregularly shaped pupil, then that can make you think that there's a disruption of the ciliary muscles or an open globe injury. We reviewed how to go through a slit lamp examination, the details of how to go through that, how to direct the light, how to set the patient up. Definitely worth a review of the details, especially on how to also do fluorescein testing with that. And there's an interesting picture in the article. Pain management with ocular foreign bodies is important. And our number one is ocular anesthetic drops. Number two are cycloplegic eye drops, as long as the patient does not have any concerns for a shallow anterior chamber or closed ankle glaucoma. And then topical NSAIDs as well for pain. In patients who have corneal lacerations and open globe injuries, we should have a low threshold of consulting ophthalmology and obtaining CT images. And we need to remember that MRIs are contraindicated for suspected ferromagnetic foreign bodies. If we can tell that a patient has a corneal foreign body, then there are several techniques for removal. The earlier, the better. If we're able to do so, we can either directly remove it using a saline soaked cotton tip applicator, especially if we had a slit lamp and it allows us to have a better view of what's going on. Or we can just try to irrigate it out using the lactated ringer solution, if possible, with tubing of standard IV and direct it tangentially to the patient's cornea, not against its surface, so it doesn't actually push it further in. There are some equipment, if they're available to us, they may help us. There's something called a corneal spud, as you shared with us, or we can just use an 18 to 25 gauge needle bent to 45-degree angle to aid in the tactility and the removal of it. Now, if that is not possible and we have access to an electric burr drill, that would be great. But again, higher injury with that just because it's more invasive. Sometimes you may see patients after the foreign body has been removed, they may present with a rust ring. If it's central, then it has the greatest effect on future vision. We need to remember that these patients need to follow up with ophthalmology because the rust will often reaccumulate the next day. So we need to make sure that they have good follow-up. It's important to avoid eye patches in patients with organic foreign bodies and patients with contact lenses. And we should always speak to an ophthalmologist before patching the eye. Last but not least, we can actually send patients home with topical anesthetics for the treatment of simple corneal abrasion for a limited period of time. So the misery of that may be averted. Thank you again, Wendy, for going through this article. And thank you again to the authors for writing it.
For our drip box this month, we're talking about acetylcysteine for acetaminophen toxicity. As we know, acetaminophen toxicity is the most common cause of acute liver failure in the U.S. and it's a common indication for liver transplant referral worldwide. And the mortality associated with these toxicity is generally low if the patient is presenting early and the condition is recognized and treated within the first 8 hours of onset. And so we do have an acetylcysteine NAC as an antidote available. And traditionally, it's administered by a complex 3-bag IV regimen. And there has been some associated adverse effects, such as non-allergic anaphylactoid reactions with this. And so there has been some recent studies that have looked at a more simplified regimen just using 2 bags, where you give 200 milligrams per kilogram of NAC over the first 4 hours, followed by 100 milligrams per kilogram over the next 16 hours. And these studies have shown that there's no difference in hepatotoxicity, while there's been a significant reduction in adverse events. So it seems like this simplified regimen is really a good approach to consider.
And last but not least, our Tox Box this month is about carbon monoxide toxicity. Carbon monoxide is an odorless, tasteless, colorless gas produced from incomplete combustion of carbonaceous compounds. There are non-fire-related exposures that occur mostly from dysfunctional residential gas combustion furnaces during the winter. Again, this is the season for that. Other sources can be the internal combustion engines, such as boats and automobiles, propane-powered heavy machinery, charcoal grills, and gasoline-powered equipment. It causes mitochondrial damage, and it damages the brain's microvasculature, binds to myoglobin, impairs cardiac oxygen extraction, and cause ischemia. It has a half-life of almost 4 hours with room air or 1 to 2 hours with 100% oxygen, which is why we use oxygen to enhance its elimination. Age about 36, exposure for longer than 24 hours, syncope and elevated lactate levels are associated with a higher risk. Patients may present with headache, nausea, dizziness, chest pain, syncope, myocardial ischemia, dysrhythmia, hypotension, ataxia, weakness, confusion, altered mental status, seizures. So clearly a lot of symptoms, and they're diagnosed with a co-oximetry CO hemoglobin, and the treatment, like we said, is enhanced elimination with oxygen. We can give them 100% oxygen until asymptomatic. And if we have the option of administering or placing them in a chamber of hyperbaric oxygen, then that would be best. If severe, such as altered mental status, syncope, a high percentage above 25% or 15% if pregnant, and dexamethasone may be a consideration for the next 3 days. Now, patients may be discharged if their symptoms are non-severe, and they can be watched until they're asymptomatic and discharged, of course, if there's no concern that this was intentional. Well, thank you, Wendy, for taking the time to go through this issue with me. I learned a lot. Our dear listeners, we hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decisions publication and our podcast always informative, often enlightening, and never boring.
Follow us on social media. My handle on Instagram is at Dr. Danya Khoujah.
Mine is at Dr. Wendy Chang.
And until next month,
bye-bye.